So, good afternoon, everybody. I'm Dr. Cristina Suarez. I work at Vall d'Hebron Hospital in Barcelona and Vall d'Hebron Institute of Oncology. And it is my pleasure to co-chair this session, session number 7, with my friend Nizar Tanir from MD Anderson. And we are going to talk about a very interesting topic, and it's advancing understanding of rare RCC subtypes. So first speaker, Dr. Teresa Alonso, will present a clinical vignette in RCC, navigating complex treatment decisions in RCC. Thank you very much. When you want, Teresa.
Thank you. Good afternoon, everyone, and thank you to the organizing committee for inviting me to be here presenting on this session. I will present during the next few minutes 2 quick clinical cases trying to show the complexity in treatment decisions in those rare RCCs. These are the learning objectives of my talk, and the first clinical case is an 81-year-old woman whose main medical history included arterial hypertension, dyslipidemia, and aortic valve replacement. In June 2016, the patient complained of constitutional syndrome for over the past 6 months, and more recently, she referred hypogastric discomfort. After the different study that was performed to the patient, the CT scan showed mainly 2 lesions in the right kidney, but also peritoneal implants and muscle implants. At this point, I wanted to highlight that those patients with rare RCC may present with different clinical presentations, and the radiological diagnosis may be quite challenging because the lesions may show variable and often hypovascular enhancement. Those lesions may overlap with benign and other malignant lesions, and there's a lack of classical imaging features. So an adequate biopsy, it's important for an accurate diagnosis. Those are the lesions of the patient in the kidney, in the peritoneal implants, and also in the paravertebral musculature. That was the place where we performed a core needle biopsy. The pathologist reported a neoplastic lesion that was, whose morphology was consistent with chromophobe renal cell carcinoma, but it is not always that easy because morphology in rare RCC may overlap between subtypes, and small biopsies may be insufficient and not capture the tumor heterogeneity. Additionally, immunohistochemical markers may be critical to differentiate some of those subtypes. As a first treatment approach, we offered the patient an active surveillance, and the patient stood on stable disease clinically and radiologically for 13 months, again showing the variable outcomes and heterogeneity in clinical behavior with those tumors. Here you can see the patient treatment journey, and in July 2017, the patient started on sunitinib due to disease progression. The patient benefited during a year, then she received nivolumab for another year, and 3 months of everolimus. As a 4th line, the patient received cabozantinib for 2 years with partial response, and in June 2021, the tumor progressed and the patient started on best supportive care. In the purple boxes, you can see the main scientific evidence on which we base our systemic treatment decisions. Those studies including patients, in this case, with chromophobe histology, and as you can see, they are mainly small-sized, single-arm, phase 2 prospective, or even retrospective studies. The second clinical case is a 58-year-old man with no relevant medical history. When he was 46 years old, he underwent a radical nephrectomy due to a renal cell carcinoma PT3. Afterwards, he continued on follow-up, and in December 2021, he had a symptomatic bilateral pulmonary thromboembolism and was treated during a year with apixaban. In June 2023, 3 new liver lesions were discovered during the follow-up, and after the extensive diagnostic evaluation trying to identify the primary tumor origin, the liver biopsy performed revealed a metastatic infiltration of an epithelial neoplasm that was arranged in solid areas and papillary structures. The neoplastic cell displayed abundant eosinophilic cytoplasm, what made this case somewhat distinctive and challenging in the diagnosis. An extensive immunohistochemistry panel was performed, with a positive expression of TFE3 that was confirmed by Frisch-Breitbart. And at that time, we could offer the patient the participation in a clinical trial. Overall, these cases show us that those patients may suffer from the misdiagnosis, as it was at the first time when surgery was performed. Those patients, they don't have a standard perioperative treatment. And also, so those rare types may present in younger patients. So it is important to consider genetic and molecular testing that is often underused. And also because there is an absence of standard treatment for metastatic disease, awareness on the need of further research, molecular testing, and the need of participation in clinical trials should be made. My take-home messages are that there is a distinct patient profile for rare RCC tumors, but frequently are underdiagnosed and lack for an accurate approach. There is a need for a greater understanding of rare RCC types to optimize their diagnosis and treatment, and I'm sure that with this great panel, during the next few minutes, this objective will be guaranteed. Thank you.
Thank you, Teresa. Our next speaker is Dr. Martin Voss, who is attending physician at Memorial Sloan Kettering Cancer Center in New York City and associate professor of medicine at Cornell. His talk is on molecular characterization of rare RCC subtypes.
Thank you, Nizar, and thank you for the organizing committee to invite me. As a US investigator, I'm very glad to be here, and it's very therapeutic for me to see all of you and be with friends and know that we're still doing all of this together, and thinking through things for our patients. So I'm asked to talk to you about molecular characterization of rare kidney cancer variants. So we're going to be talking about ways to integrate this into clinical pathways, but also into research strategies in the future. And obviously, these days, molecular characterization plays into all kinds of aspects of kidney cancer care, diagnosis, prognosis, and then the obvious elephant in the room to medical oncologists is how to choose the appropriate systemic therapy for orphan diseases. And for diagnostics, molecular profiling, of course, through immunohistochemistry has long been a part of pathologists' work, but through the years with the various iterations of the WHO criteria, increasingly is integrated now into diagnostic classification of patients. And you can see that this was already more present in the WHO criteria in 2016, but the current 2022 classification now actually defines various subtypes specifically through molecular means. Good examples being ELOC mutated RCCs on the top, which are indolent tumors typically, and then at the very bottom, and very rare ALK-rearranged renal cell carcinomas, which are now recognized as their own entity. I did have some slides on prognostication, but Nizar in his wisdom has asked me to cut down the number of slides in my slide deck, so I'm going to have to somehow talk to that while I talk about systemic therapy. And this sort of is an overview that I put together to show not so much the individual details, for these phase 2 and 3 trials that have been reported, but more so the current thinking or the thinking up until here of how we, try to stratify patients with rare kidney cancer variants. We think about them really, and you've seen that in this session, the session before, in these very large buckets of non-clear cell subtypes, papillary, chromophobe, and unclassified RCC being the most commonly used. And then what we do is we reapply paradigms that we defined in conventional kidney cancer, so clear cell paradigms. And we are moderately successful and some less successful in others. And my point here is not so much to talk about what works where, but to suggest that we have to depart from this strategy and think more in other ways about rare kidney cancer variants. And we can learn from colleagues in other diseases. So this, of course, is best established in non-small cell lung cancer, where our friends and colleagues for years have worked very hard to integrate molecular profiling into their day-to-day clinical lives and have carved out these very small subsets of patients that are molecularly defined with actionable targets and now FDA-approved agents. And we often, in our own conversations, will say, well, it's not feasible to develop a strategy for something that's only prevalent, present in 5% of our patients, where the lung cancer docs have actually, worked past that threshold. I put this pie chart together just using TCGA data from the papillary TCGA, right? So you can think about the kidney cancer subtypes in a similar way, and you can think through actionable alterations. I quite enjoyed Dr. Rizzo's presentation before when she spoke to actionable alterations across non-clear cell variants. We've spent a lot of time in our own group thinking through this, and she mentioned once or twice OncoKB, which is a Sloan Kettering effort that's been going on for years now. So we have an in-house assay that's very similar to Foundation Medicine, and it's germline controlled. And when patients consent to and have their tumors analyzed for molecular annotation here, the treating physician and the patient ultimately get a report like the one that you see over on the left here. And we have this OncoKB knowledge base, which is a growing database of annotation, clinical annotation of molecular findings, which integrates both clinical and preclinical data that helps interpret the information found on NGS testing. And on the right-hand side, you see a figure from one of the early papers. This was after the first 10,000 patients had been stratified across diseases at Sloan Kettering. And we did a comparison across different cancers, and I'm the kidney cancer representative on that panel. And you see here with the red box that RCC doesn't tend to have a lot of actionable mutations. We published a paper subsequently, and this is now some time ago, that's very similar to the analysis that Dr. Rizzo showed before. And we looked at non-clear cell kidney cancers, and we looked into OncoKB and tried to outline what proportion of patients have actionable mutation and what level of evidence is there. And the level of evidence is quite low for the kidney cancer variants, but we showed something quite similar to what you saw just a few presentations ago. And we can think through kidney cancer variants now, with molecular background in mind. So for instance, within papillary kidney cancer, the one entity that is best defined is MET-activated kidney cancer. And there are various folks in the room here who've put a lot of work into this. And I put these two trials on here, Savoir and Sameda, as two relevant trials that I want to highlight, not so much because of the findings around efficacy or where things stand from a registration perspective, but because they demonstrate that our field is able to enroll patients on molecularly defined trials, right? These are remarkable efforts that for the first time showed us that a phase 3 study can be set up and accrued to with patients that enter based on tumor profiling. Here's another type papillary variant that is fairly well defined, both in WHO and also in all of our practice, and it's FH deficient papillary kidney cancer, which you can identified by means of immunohistochemistry, but you will all often pick up on NGS panel testing now. And this is all work from our own group, but there's others who have published. There was a recent study out of China that was published, that was presented at GeoASCO, if you remember, earlier this year. And essentially, a couple of points that are relevant to make for FH deficient papillary RCC. For one, there's a very high proportion of germline events in these patients. On the left-hand side, you see a group of patients that we published on. They're all metastatic. But within the metastatic setting, the majority of these patients actually had lost FH in the germline prior to developing disease. And in those patients with HLRCC syndrome, there's a very high lifetime risk of developing papillary kidney cancers, which are high grade. And then on the right-hand side, there's two phase 2 trials that we've run through our group here that have looked at papillary variants and then in a subgroup analysis specifically looked at molecular annotations within these. I think we should be doing this on all of our non-clear cell kidney cancer trials. And what we found from those two, that these patients can do, at least on the short term, quite well with combinations. So on the top, you see mTOR plus VEGF inhibition, and the majority of patients had PFS benefit. And the radiographic RECIST response rate was north of 50% for these patients that have very aggressive disease. And then at the bottom, you have cabozantinib nivolumab. And here, again, we had a high response rate. In this case, the radiographic response rate, again, was over 50% of the patients. And I do think we need to annotate other data sets like the B61 study and so forth to help us think through these differently and know what to do for which type papillary variant. You saw in the prior presentation, you saw it in the OncoKB data here, CDKN2A loss is quite prevalent, and indeed it is very prevalent across all kinds of solid tumors. In papillary kidney cancers and unclassified kidney cancers, we see it in about a quarter of the patients that we sequence. And CDKN2A encodes for P16 and P14, so it's relevant for G1S transition, but it also is currently loss together with a protein called MTAP. So they both sit on the short arm of chromosome 9, and oftentimes there's loss of heterogeneity that then there's a double hit when there's a focal deletion in either of the two. But one thing that is relevant to know is if you see someone who's got CDKN2A loss, and most assays will now pick up on that quite easily, they often have concurrent MTAP loss based on where in the chromosome these are and how close they are together. And MTAP is not often tested for on all the various NGS assays out there. And MTAP loss, if it's biallelic, is actually now actionable. This is from a paper that was recently published, an all-solid tumor trial that showed that if you affect the pathway and MTAP helps keep a balance here in methionine salvage, you can actually have an anti-cancer effect. So it is important to keep that in mind, and you can refer patients to trials outside of our own field to pursue molecularly directed therapy. Unclassified kidney cancers are really a bucket of cancers that we don't quite understand. This is from a paper that one of our pathologists published a few years ago, and if you look at the oncoprint, you see that there's different subtypes of unclassified RCC that have mutually exclusive genomic phenotypes. NF2 loss and mTOR activations are seen, and these patients, again, won't have both. It's mutually exclusive, and the clinical phenotype, risk of recurrence, aggressiveness, and so forth, is quite different between these two, and particularly NF2 is relevant. Loss of NF2 activates the Hippo pathway and now is also targetable in studies that are still outside of kidney cancer but may prove to be efficacious. So TEAD inhibitors are now in the clinics, and you could refer patients to phase 1 programs that have some of these available to you. And then the last segment here, obviously, we pick up on these things, and we should think more about germline loss, particularly for non-clear cell variants. The rate of being diagnosed with kidney cancer and having a familial background is higher in rare kidney cancer variants than in clear cell RCC, and it is our practice, in my group anyway, to send all metastatic non-clear cell kidney cancer patients for germline testing and ultimately clinical genetics as indicated. So take-home messages, what does this mean for my practice on Monday? So in my practice, all patients with metastatic non-clear cell variants should have their tumors sequenced, if only to learn for the next generation of patients, but also to open opportunities of clinical trials outside of our own program to them. I do think, I said that before, that they all also should have germline testing. For us, that's one assay, but if I had to consent them twice, I would do so in the interest of their families. What does this all mean for the future of care? I do think we have to, for the time being, think about trials that are outside of RCC land, because they may actually help us understand mechanism-directed therapy better and bring molecules to us so we can do more trials like Semeda and Savoie that are actually molecularly integrating and bringing the patients on not only based on their histologic variant. Thank you very much.
Thank you, Martin. Our next speaker is Dr. Gabriel Malouf. Dr. Malouf is professor at the University of Strasbourg in France, and his talk is about collaborative efforts in rare RCC, the French National Network as a model for collaborative research and patient care. Gabi.
Thank you, Nizar, and thanks for the organizing committee for the opportunity to present the efforts we are doing in France with colleagues, pathologists, urologists, and medical oncologists to try to serve the community of patients with kidney cancer. So I'm a medical oncologist. I've been working on rare kidney cancer for the past 15 years. And I will present to you during this talk the organization of the French National Rare Kidney Cancer Network and the mission of the network with the objectives and how we try to serve the population overall. So first, I would like to say that in France, we have a social system and the healthcare for everybody. And the National Cancer Institute organized the things in a way where they want that each patient, with whatever type of rare cancer they have, they can be treated equally across all the nation and across all the cities. So they established networks. So you have networks that are all like sarcoma, lymphoma, but we have also a network for rare kidney cancer that is really emerging. And the network has to fulfill 9 missions. They necessitate to have pathological and clinical expertise, access to specialized care for all the patient, do information for the patients, for their family, coordinate the healthcare stakeholders, optimize the pathways of the patient, contribute to the guidelines, the recommendation, improve the education of the professional, promote clinical trials, and do epidemiological surveillance and data management. And in France, we have around 17,000 cases per year. The incidence is increasing. It's increased, it doubled in the past 20 years, with over 5,000 deaths. And we estimate that non-clear cell is 25% of these tumors. And if we want to do a good job, we need really to have tools that we can characterize them. And this has to be done at the nation really level. The issue in France is that we don't have a place where all the surgery are done. So the surgery is performed in 462 hospitals. Oncology and pathology are distributed across really heterogeneous clinical setting. And with the new classification, so Martin alluded to the classification, we have 11 types of molecularly defined entity, and for those we need really to search for them. So in France, the CARAR, so the Rare National Kidney Network, has been established by Bernard Escudier 10 years ago, and it allowed really to structure the reading of all the cases with rare kidney tumors in France, because we have 15 pathologists all over, and when the pathologists think that this case needs to have a double reading, they send it to the expert pathologist, and therefore they can do all the tests to have accurate diagnosis. And after 2019, we got some funds from the ANCA, and we worked with the medical oncology group, the GETUG, with the surgeons, the AFI group, to structure this network, and I will show you how and what are our challenges. So currently, we work together with the urologist, or Jean-Christophe Bernard, who's the urologist, medical oncologist. So Professor Riou Leclerc is pathologist in Rennes, coordinating the effort, and I'm coordinating the effort of medical oncology. And here among the medical oncologists, we have Laurence Elbigès, we have Professor Oudar. We are many that work together to try to do the job for the nation. So in terms of pathology review, the 15 expert pathologists review 1,200 cases per year. Out of those, 600 are confirmed as really rare kidney tumors. They do a tumor review every month for complex cases, so they review 120 cases among them. And all the papillary RCC cases, they look for molecularly defined entities, so FH, SDHB, SMART1, TFE3, TFEB, and ALK. So it's really done at the national level, and at the end of the pathology report, they indicate that the case has been registered and require the National Care Multidisciplinary Tumor Board. And this is important because we launched a national tumor board, so it's online in 2023. So the physician can fill online the natural history of the disease of the patient. And we have a system of rotation each 15 days where we have 2 pathologists, 2 medical oncologists, and 2 urologists that are present. And we discuss around 20 cases to 25 cases each 15 days. And here you will see the graphs of the online MTD, where we begin in 2023, we have 175 cases. In 2024, we have 348 cases that has been discussed. Essentially, these are metastatic cases. We have some localized cases, but this is really important because there's a need in the community for that. And the cases has been discussed from over 114 hospitals that needed, recommendation for their patients. Median patient's age for what has been done for the last 2 years, the patient is 61 years. We give a quick response. The median is 5 days for the report. And over 50% of the patient, when the case has been discussed as a tumor board, has been already seen by the expert pathologist. And if it's needed, we usually ask the physician to send the case for the expert pathologist to have really accurate diagnosis. Often the cases present are aggressive, as you can see, with 33% of the cases have really poor risk, and we have to give recommendation right away. before having from time to time the accurate diagnosis. If you look at the histologies, it's different from what you have seen before. Maybe we have a bias, but we have only 32% of Papay RCC. We have 20% of chromophobe. We have 9% of TFE3. We have 7% of FH deficient tumor. We have 2% of SMART1 deficient tumor. So as you see, we have all the different histologies there. And this is very important at a national level to ensure how many patients we can have, because if we have a clinical trial that are open in a specific disease, we can accrue the patients very quickly. And this is really different from what you see from the MDC. In their papers, they have papillary, chromophobe, unclassified, and collecting duct. So this is, I think, effort to divide this tumor in molecularly defined entity is really important. And we would like to expand on that. So we would like to integrate some geneticists with us, that they can be present, at this tumor board to know if we need really to send all the cases for counseling or not. And with the number of cases now, I hope that will help us to have investigator-initiated studies that are focusing on specific, subtypes and describe the natural history of those subtypes. And we hope that with the structuring of the network, we can pilot AI-enhanced diagnostic pathology workflow, because we have enough cases. So I think with time, we would be able to implement that quickly, because now it's taking too much time to have the reading of those cases, and build a patient advisory board that we can see how really we can help the population. So as I said, CARAR is something unique at the global context, because we integrated at the national level the pathology, the medical oncology, and the surgeons together. And we have some initiative in Europe with Eurocan, but it's really broad and it's not really dedicated to RCC. In the United States, we have some efforts also in the NCI, which are really very good. My part also for translocation renal cell carcinoma, but they are really focused in some network centers. And I think we need to learn how to work together across countries to improve the understanding of these types of rare patients. So take-home messages. So what you are going to do on Monday, I think, of course, this will not change your practice, but it's important to think that rare kidney cancer necessitates a multidisciplinary team. You have to have a good pathologist, a good surgeon, a good medical oncologist, and it should benefit from national organization with collaboration from pathologists, because if the disease has not been read by expert pathologists, you might think that it's really clear cell RCC, and the patient might not get the accurate treatment. And rare cancers are really structured in France in networks, allowing to reduce the disparities across regions and improve patients' management. And I hope in the future we can show you real data from this network. Thank you very much.
Thank you. Thank you, Gabi, and thank you for staying on time. Perfect. Our next speaker is Dr. Lisa Hensky. Dr. Hensky is a professor of medicine at Harvard Medical School and an attending physician at Dana-Farber Cancer Institute and the Brigham and Women's Hospital in Boston. Her talk is on chromophobe RCC clinical and molecular perspectives.
Thank you, Nizar, and thank you so much to the organizers for the chance to present at this amazing meeting. I want to just start by acknowledging the really amazing people I'm fortunate to work with in Boston and elsewhere who have helped make some of these discoveries related to chromophobe kidney cancer come about. I'm going to be discussing unpublished data today from 2 postdocs in my lab, Samer Salem and Michelle El-Shaweri. So you already know that the hallmarks of chromophobe kidney cancer include whole chromosome losses, a relatively low number of driver mutations, with p53 having the highest mutational rate, the highest mitochondrial DNA mutation rate at high heteroplasmy in the TCGA. And the hallmark I really want you to remember is these really high levels of glutathione, 50 to 100 times higher than in matched normal kidney. And what's traditionally been thought to be a low response rate to tyrosine kinase inhibitors and immune checkpoint inhibitors, although that may be changing, and median survival in the metastatic setting of less than 2 years. And this captures the two pathways we think are relevant. One involves mutations in nuclear genes, including in the mTOR pathway, and the second involves mutations in mitochondrial genes, including ND4 and ND5. So traditionally, we believe that there was not such a great response to immunotherapy in chromophobe RCC, but two recent trials challenge that. One is the Keynote B61 trial showing a 28% response rate, and the second is the Sunny Forecast trial, which will be discussed tomorrow, actually, with a 27% response rate. And I think most importantly, these trials have a lot of individuals with chromophobe kidney cancer in them, so that will really allow us to learn so much more about the clinical response in chromophobe. So we believe that chromophobe tumors are hypersensitive to ferroptotic cell death, and the reason that we started looking at that is because of this very high level of glutathione. Now, you might have thought that having these super high levels of glutathione would mean that chromophobe tumors would be resistant, quite resistant to ferroptotic death, because ferroptosis is a cell death mechanism that's initiated by oxidant stress. But in fact, we found that chromophobe cell lines are very sensitive to ferroptotic cell death, both in vitro and in vivo. And we think that's because chromophobe tumor cells have a very high level of oxidative stress, and they need all of that glutathione to survive the oxidative stress. So if we inhibit their ability to make glutathione, for example, by inhibiting uptake of cysteine, the tumors undergo ferroptotic cell death. This is just an example of this in vitro, showing that the two chromophobe cell lines are more sensitive to blockage of cysteine uptake than a clear cell kidney cancer cell line shown in blue, 7860. And we also see benefit of inhibiting cysteine uptake in these tumors in mouse models. So what we're looking at now in unpublished data is a different mechanism of ferroptosis sensitivity that's regulated by ferroptosis suppressor protein 1. And you can see here in orange that chromophobe kidney cancer in the TCGA has the second highest level of FSP1 of any of the profiled tumors. Here we're comparing the tumor level of FSP1 to the matched normal tissue. Endometrial cancer happens to have the highest, and you can see the clear cell and papillary are in the middle. And we also can see from the TCGA that high levels of ferroptosis suppressor protein 1, or FSP1, correlate with worse overall survival in chromophobe kidney cancer, and we think that might be reflecting this even higher oxidative stress capacity. So what is FSP1? FSP1 is the same as CoQ10. FSP1 regulates the reduction of CoQ10 and ubiquinone. You could buy CoQ10 from Amazon if you wanted to. So it regulates the reduction of this, and then FSP1 is able to, by reducing ubiquinone, is able to directly modulate oxidative stress on lipids. So it's a way to trap these lipid peroxides. So if we inhibit FSP1 using one of several different inhibitors, I'm just showing you one of them here. We used about 10 concentrations of the inhibitor of FSP1 and about 10 concentrations of IKE, which inhibits cysteine uptake. We see a synergistic benefit. So you can see in the bar graph in gray that with no drugs at all, normalized viability, we see a little bit of reduction in viability with the IKE, or the cysteine uptake inhibitor alone. At this particular dose, which is 20 nanomolar, we don't see micromolar, we don't see an effect of the FSP1 inhibitor alone, but with both we see synergistic induction of cell death. And we see the same in other cell lines and also in using other inhibitors of FSP1. And we've also moved to study this in vivo in xenograft models using the UOK276 cells, which were originally developed by Marston Linehan. So what you're looking at here are tumor cells that are transduced with either a control shRNA or shRNA for FSP1. And the FSP1 knockdown tumors are smaller in every case. So we believe that FSP1 is a logical target in chromophobe kidney cancer, and efforts are underway through several labs in the US and perhaps elsewhere to develop clinical FSP1 inhibitors. So I want to briefly turn your attention to the membrane tyrosine kinase KIT. So KIT is very highly expressed in chromophobe. Here you're looking at all of the TCGA tumors. It's the highest in chromophobe of any tumor. And that is because KIT is expressed by the cell of origin of chromophobe, which is the renal intercalated cell. And you can just see on the right in the dot plot the high levels of KIT in most of the chromophobes from the TCGA. Now, we know that KIT is definitely not mutated in chromophobe kidney cancer like it is in GI stromal tumors, and we don't really believe it's having very much effect on driving the tumor cells through its activity as a tyrosine kinase. But it is a very attractive target for an antibody drug conjugate in chromophobe kidney cancer. So we've begun to take some steps toward trying to understand that. We do see in the tumor bank samples that we have from Brigham and Women's Hospital that KIT is expressed in about 75% of the metastatic tumors that were profiled for KIT. And we also see that it's expressed in our cell lines, which is lucky for us because we can study it. So we've tested an antibody drug conjugate that was developed by Novartis years ago. And you can see in this plot a dose-dependent reduction in cell viability when the cells are treated with the KIT antibody drug conjugate. This is one of our cell lines, the UK276 cells. And in 2 additional cell lines, we also see benefit of this KIT antibody drug conjugate. And as you might expect in the 7860 clear cell derived cell line, we don't see any effect of the antibody drug conjugate. Clear cell tumors don't express KIT. So we think this is an interesting target that could be useful in the treatment of chromophobe kidney cancer. So what are the take-home messages? First of all, there are encouraging results from immunotherapy in 2 recent trials that we really need to understand better and think through and envision the best ways to use immunotherapy in chromophobe kidney cancer. Secondly, more on the research level right now, there are very high levels of glutathione in chromophobe tumors. And in cell lines and models, we see hypersensitivity to ferroptotic cell death by either inhibiting cysteine uptake or by inhibiting ferroptosis suppressor protein 1. And lastly, chromophobes have very high levels of KIT, which probably reflects their intercalated cell of origin, and that leads to the potential for KIT antibody drug conjugate therapy in the future. Thank you very much.
Thank you, Lisa.
Thank you, Lisa, for the great presentation. And now, last but not least, my co-chair, Ms. Artani, is going to talk about a state of research in variant histology RCC, non-clear RCC, challenges and new opportunities.
Thank you very much, Chris. And I'd like to thank the organizing committee for the kind invitation to co-chair the session with my colleague and friend, Dr. Suarez, and to speak to you about my views on this state of research in variant histology, RCC, also known, or we refer to often as non-clear cell RCC, challenges and opportunities. So these are the learning objectives I'd like to share with you, a review of the current clinical and translational research status in variant histology RCC, increase our understanding of the biology underpinning some of these rare RCC types, and leverage the technological advances and lessons learned from studying renal medullary carcinoma and other rare types, such as chromophobe, which you heard from Dr. Hansky, translocation RCC, HL-RCC, to develop effective therapies for all rare RCC types. So what are some of these challenges we've faced so far in this area? These are some of these challenges. Low incidence, as you know, these are rare tumors, and many pose high heterogeneity. Even in a rare tumor, you have, for example, translocation RCC. It's a very heterogeneous. You can consider it as a diverse within this entity. Collecting duct carcinoma is still difficult to make that diagnosis, and there is a divide across the Atlantic on how to make that diagnosis. In the US, we frequently don't really call collecting duct easily at MD Anderson. Limited patient numbers for robust clinical trials. As we heard from Dr. Malouf's presentation, delayed diagnosis and misclassification. Some of these rare tumors are often misdiagnosed as common RCC subtypes, and the lack of standardized pathological expertise. There is sparse molecular and clinical data, limited genomic profiling data sets, and few established preclinical models. Therapeutics not grounded in biology, and we have adopted the clear cell RCC therapies to treat some of these variant histology RCC, what you heard from Dr. Martin Voss. So there are few prospective disease-specific trials, which is a good start now, but we need to do more. And of course, funding and visibility gap. These are under-prioritized in research funding, and rare tumors are overlooked by large cooperative groups. So where were we in this? For example, collecting duct I just mentioned. This is historical data with chemotherapy showing some responses, and more recent therapy, cabozantinib, applying again the therapies for clear cell into this rare disease, and with cabozantinib. But really, these patients are not having lasting responses and unfortunately succumb to their illness. What about now? Translocation RCC. We looked at 29 patients, all confirmed by FISH, and treated, again, as we treat patients with clear cell, with nivo-ipi. Among 18 patients treated with nivo-ipi, only one had a partial response. And among 11 patients treated with IOTKI, 4 had responses. But both cohorts had a dismal survival of 13 months. So we need to do better. Now, here are some of the trials in papillary where there is a target. We have MET alteration as a validated target for some of these for papillary RCC. But I would like to pitch the notion that we really need, well, these are important trials, but in my view, they really are driven by industry towards study drug approval, and we need to really focus on target discovery that's relevant and specific to these rare tumor types to advance the field. So what are these opportunities to accelerate progress in variant histology RCCs? Precision oncology and technological advances, as I mentioned, target discovery for each of these variant RCC subtypes to enable more effective therapeutic tumor targeting, biomarker-driven studies, and I'd like to show you in the next few minutes that at least we have 2 biomarkers that are now hopefully will be validated by other groups in HL-RCC and in renal medullary carcinoma. Using mouse models, we can study tumor evolution and mechanism of metastasis and development of drug resistance. We really need international collaboration. It's going to take more than a village. It's going to take a global collaboration to really make progress. Innovative clinical trial designs focusing on adaptive trials tailored for rare tumors. Emerging therapeutic avenues, some of these therapies are listed here, advances in pathology and imaging, and patient advocacy and policy changes. So you heard from Dr. Henske about chromophobe. I would like to now share with you some of the findings, late findings, emerging findings in these other 3 rare tumor types. So we've known for a while now, for more than 10 years, that for HL-RCC, there are 2 targets, VEGF and EGFR, and then this is a study that was launched at the NCI more than a decade ago with bevacizumab and nilotinib showing high response rate. We heard at ASCO GU a study from China in 20 patients with 90% response rate with an anti-PD-1 and lenvatinib. And, but unfortunately, we really need to do better and find biomarkers. And this is a biomarker that I think, if validated, will be really important for our patients. Succinic cysteine is an excellent pharmacodynamic biomarker that can monitor residual and recurrent disease. Fumarate is effective electrophile that oxidizes reduced cysteine. Fumarate chemically depletes GSH, glutathione levels and activity causing redox stress, and SC is enzymatically degraded to 2SC in the kidney, and 2SC is an excellent circulating metabolic biomarker for early detection of fumarate hydratase deficient RCC and for monitoring residual diseases. And here is, fumarate hydratase deficient PDX confirming SC2SC as an excellent longitudinal diagnostic biomarkers. In the top right panel, you see the IHC stain for 2SC in the middle, and the fumarate hydratase negative in these mutant FH. And you see in the sera, there is high concentration of 2SC in these tumors that are FH deficient. And then in patient samples, you can see there in red that over progression of the disease to stage 3-4, you have high levels of 2SC in the circulation. Now, progress is being made in translocation RCC. This is the work of the folks at Dana-Farber and Shirini lab. And here is, starts with target discovery using unbiased genetic and chemical screen and molecular characterization of patient specimen toward target discovery, moving to validation of these targets in mechanistic studies in patient-derived xenografts, and ultimately to get to the clinical trials. But we're not there yet. And they have identified 2 targets for translocation RCC, at least in the most, for this diverse among the most of these partners. And then one of them is EGLN1, which inhibition impairs oxophos and is vulnerability in TRCC. They showed that knockout of EGLN1 in translocation RCC stabilizes HIF1 alpha and reprograms metabolism away from oxophos, selectively deleterious to translocation. There is small molecule EGLN inhibitors are clinically approved. To the right, there is work they found recently, it's unpublished data, where they have identified a surface antigen that is selectively present on the majority of these translocation RCC cases, and they're developing now therapies with BiTEs, bispecifics, and CAR-T, hopefully coming to the clinic soon. Now, what we did with RMC here many years ago, we published this in Cancer Cells 5 years ago. We identified chromosome 8q gain and chromosome 22 monosomy, inactivating SMARCB1 translocations, big induced replication stress, recurrent focal copy number alterations, NOT activation, UCA1 upregulation, and CGAS-STING upregulation in RMC. Up till recently, there hasn't been any RMC models. We've since then have 4 cell lines, RMC cell lines, and 3 PDX models have been generated, including a somatic mosaic model of RMC. And then we identified EGFR as a target in RMC. And here is from bed to bench, we went and looked at bevacizumab and erlotinib, which is an active agent in HL-RCC, as I showed you. We thought that in patients with RMC, which is similar in its avidity to FDG uptake, it's very metabolically active. So we tested this in patients, in 10 patients, and we found that there were 2 PRs. We went back to the bench and found that in this experiment, really targeting the EGFR was the important and not bevacizumab in RMC. And now we have some clinical vignettes that I will share with you. Here is a patient who was heavily pretreated with chemotherapy, with paclitaxel and carboplatin, then ixazomib, gemcitabine, and doxorubicin. And we treated this patient with a triplet of paclitaxel and carboplatin plus panitumumab, an antibody against EGFR. Here are his scans before treatment. There was hospice discussion, and then after treatment, the patient had a fantastic response, and he's now 2 years out in remission with panitumumab. Now, hypoxia and ferroptosis are hallmarks of RMC that basically explains why RMC is resistant to VEGFR TKI. And from Boston gene NGS, we identified TROP2 as a target in some of these cases with RMC. Here is a patient who had a PR, patient of mine treated with sacituzumab, but unfortunately the response was 6 months. So we need to do better, and we are doing better. A marker that we have identified is CA125 in about 2/3 of patients with RMC. Now, MUC16 is proliferatively cleaved into the circulation, shedding CA125, and there is a membrane-associated C-terminal domain that remains on the cell surface. This now is being used by our group as a target, and we have now a trial with a bispecific target, and that's the RMC model that I would like to finish this presentation with. RMC, for many of you, may not know this disease, is the most virulent RCC type. It afflicts a young African American with sickle cell trait. We have established a robust translation and reverse translation pipeline supported by a unified data science framework. And we have identified some targets for RMC, as I showed you, EGFR, MUC16, and TROP2. Several trials have completed accrual, and new trials are targeting MUC16, TROP2. And survival has improved from 4 months back in 1995 in the Davis publication to 13 months in our publication 8 years ago, and now 18 months and going. We hope that by the end of the year we'll have 2 years survival for these patients, and in 5 years, in 2030, we will have hopefully a survival of 5 years. So in our experience, up to 10% of these patients who have virulent disease now achieve 5-year survival. Take-home messages. I hope I shared with you that there is promising research in variant histology RCC, and this is ongoing work with novel tumor targets and biomarkers that have been identified in at least HL-RCC and RMC. Trials in variant RCC should be histology specific and driven by biology and not applying what we treat our patients with clear cell with. But it remains that we have to really do this via an international academic collaboration and partnership with industry. This is essential to move the field forward, and this is the most important. I would like to thank you for your attention. I would like to thank our patients and families who inspire us to do this work. I'd like to thank several people. Some are here on the stage. Gabriel Malouf, who has been a collaborator and a friend for 16 years. Pavlos Musaul, who has been really moving the field of RMC, and Giancola Genovese, who does a lot of the mouse models at MD Anderson, and then Dr. Eyal Gottlieb, who I'm collaborating with on HL-RCC and defining and validating the biomarker. I showed you 2SC in patients with HL-RCC. Thank you for your attention.
Thank you very much, Nizar, and congratulations for the great presentation. So, do we have any questions from the audience? Okay, I will start with.
Do you have a question?
I have some questions. So, okay, we'll start one question to Gabriel. I don't know if you have this data. How many patients, or what is the percentage of patients that were reallocated to a different histology after that second reading? Do you have this data?
Yeah, we don't have really statistics on the number of cases that has been allocated. So now we need to take all these cases and analyze again. So if you have two approaches. The first approach is you analyze all the tumor by expert pathologists, which is very complicated to analyze the 15,000 cases. And the other one is if the pathologist feels that he's not comfortable with the diagnosis, he sends it, or if the patient has a metastatic disease and there's a possibility that an accurate diagnosis changes the things, this is sent to the expert pathologist. So this is the way we took pretty much in France. If you need to read everything, it's not possible with the people that are available, but metastatic cases definitely need to be reread, and I don't have the statistics exactly, but I hope that we can provide that.
Thank you.
I have a question for Lisa. Lisa, great talk. Chromophobe can be associated with sarcomatoid features and makes the disease very virulent. Have you looked at these cases of chromophobe with sarcomatoid to see if, FSP1 or does, the kit on the surface changes? I mean, do we have a different target that we can go after? I mean, we have published recently, series of patients treated with nivo-ipi, including 12 patients with chromophobe. 8 of those had, 3 had responses out of the 12 chromophobe, but all 3 had sarcomatoid, and so they responded to nivo-ipi, but it wasn't durable. Ultimately, these patients, unfortunately, do succumb. What is your, other than FSP1 and c-KIT, do you feel like there is something else in these tumors that degenerate and have sarcomatoid dedifferentiation?
Yes, we're very interested in the sarcomatoid component, and in particular whether the tumor immune microenvironment might be different. And we've just completed some xenium spatial profiling on tumors where both elements are present in the same tumor. We don't have the results yet, but we agree that it's a very important area to understand in more detail what exactly is going on in that transition between the conventional and the sarcomatoid.
So the other question on c-KIT, sunitinib targets c-KIT among, all VEGF and FLT3, et cetera, and you would like to maybe develop, an antibody drug conjugate against c-KIT for chromophobe. Have you done any work already in models? And do you believe this would be an effective strategy, since we do not really know if KIT is driving this disease? You mentioned that we don't know if it's really a driver. We know that FSP1, but what is your talk on ADC as an effective strategy against KIT?
Well, we don't think that KIT is particularly active, and most of, like imatinib, for example, inhibits the mutant form of KIT much more than it inhibits wild-type KIT. So we're not that optimistic about tyrosine kinase inhibitors of KIT being significantly efficacious in chromophobe. I think the use of KIT as a marker that could be used for antibody drug conjugates may be a better direction.
I have a question also for Lisa, and maybe Martin would like to answer as well, because you are also an expert in chromophobe tumors, I know. So what is your standard of care in clinical practice for chromophobe tumors? And the second question is there still a role for mTOR inhibitors?
So I'm happy to answer. So I don't know that there's a standard of care. I have myself, found that my initial aversion towards immunotherapy has gradually gone away. What we've seen, and we haven't looked at these data sets so much in today's session, but what we've seen in the non-clear cell trials that have looked at IO monotherapy, TKI IO combinations, and IO CTLA-4 PD-1 doublets, that there are always some chromophobe patients who can respond to these agents, but that across the board, the proportion of those who respond for any IO-containing regimen are less than for any other variant, clear cell, papillary, unclassified even. So there certainly can't be so big a reliance moving forward onto PD-1-based regimens as we may have for other entities. So I think there's a need to look into these. That said, they can respond. mTOR inhibition, I think, can be successful more so in chromophobe than in some of the other variants. But that's the very early data that Nizar and others showed that back in the molecularly targeted days, that the proportion of patients who had PFS benefit from mTOR inhibition were greater. And I still do think that the mTOR-VEGF combinations can be very active. There's not a lot of prospectively published data out there. There's small data sets, but in my own practice, I see those respond well. So in the front line, I do give patients the benefit of the doubt with checkpoint-containing therapies, but I do always come to mTOR inhibition at some point with the chromophobes, which I don't really do with clear cell kidney cancer. So in the second line, I often use mTOR-VEGF combinations, albeit there's a lot of toxicity, so it's not so easy always.
I think, Chris, if there is a tumor where you really, I think, would be helpful to do NGS, would be chromophobe and unclassified, because if you identify TSC1, TSC2, mTOR gene alterations in chromophobe, I think they will be more responsive, and that response could be durable. I've had such a patient. She is now 12 years out. She had metastatic chromophobe. We had her on the ESPN trial. She had a 9 months response to sunitinib first line, and then with everolimus, she had now 12 years in CR. That's durable, hopefully cured, and she had a tumor that was TSC1 driven. So that's what I would think would be something to...
I have a patient that has been, in fact, I didn't start the treatment because I was not there at that moment, almost 20 years with temsirolimus.
Yeah.
On, off, of course. And when he progresses, we reintroduce temsirolimus, and he
responded again,
and then, so almost 20 years, temsirolimus.
So I think, the data from Sunny Forecast, we'll hear about it tomorrow, but I think the 26% ORR, Lisa, that you showed from Sunny Forecast in chromophobe with nivo-ipi, I don't think they have really described if these, I don't remember the number of patients, whether they had sarcomatoid differentiation. As I said, in our experience, if there was a response to nivo-ipi in chromophobe, they had sarcomatoid differentiation. And I think, from the Keynote B61 trial that Laurence led, this 28% response rate, in my opinion, is mostly driven by lenvatinib, with maybe a little bit of contribution from pembrolizumab. But I think, again, second what Martin was saying, I think mTOR inhibitors and VEGF RTKs are still active in chromophobe. I think they should definitely be considered for these patients at some point. I think we're out of time. I'd like to, you have a question? Dr. Sala, yes.
Just one quick question to Gabrielle. So you're collecting the data on the tissue on those patients. Are you also collecting the data on the results of their therapy?
Now, basically, what we begin now is we launch the clinical feasibility of the tumor board, and now it's working, as you saw with the numbers. So now the next step is to collect the clinical data with the samples that we can do biology on those samples.
Well, if there are no other questions, thank you very much for your attention and for attending the session. Please stay seated for the next session. Session number 8 will be starting soon here, and it's on KCA update by KCA Chief Scientific Officer Salvo will be on stage, and we're going to listen to the exciting keynote presentation on microbiome in kidney cancer by Dr. Lisa Rosa.
Thank you very much, everybody.